Hi, I'm Bill Rapisi, Executive Director of Lymphatic Education and Research Network, and I just want to take this opportunity to thank all of you for joining us today for our Symposium series. I also want to take this opportunity to thank all of you who become members of LE&RN and help support this series so that we can continue bringing this kind of groundbreaking information to you in your homes and offices. I would also suggest for all of you who have not become members of LE&RN, $5 a month, you can become a member of LE&RN and help support this programming and the research that we do. Thanks very much for joining us, and I look forward to having you become a member.
We want to welcome you all to the LE&RN Symposium series. And first of all, we definitely want to thank LE&RN for giving us the opportunity to talk to you today. So today, Carrie and I would like to talk to you specifically about a specific class of lymphatic disorders called lymphatic malformations. So first, I just want to put it in context. According to the ISSVA Classification, which is the International Society for the Study of Vascular Anomalies, lymphatic malformations are grouped as a co-class of vascular malformations. As you can see, there are vascular tumors and malformations, and today we're talking about malformations. And these malformations are further subdivided according to their flow characteristics, fast flow or slow flow, and lymphatic malformations are slow flow malformations. And as you can see, malformations are subclassified into the type of vessel that is involved. So people can either have pure lymphatic malformations, or they can have a combined malformations with lymphatic, venous, and capillary malformations all combined. The lymphatic system is part of the circulatory system, and it is almost an orphan in the circulatory system. Everybody learns about the arteries, the veins, and the capillaries back in high school biology, but the lymphatic system is rarely mentioned at that time. It is a system that is complementary to the blood circulation, and it actually has a lot of very important function. So in the circulatory system, blood gets pumped out of the heart via the arteries to supply oxygen and nutrients to the tissues, and that exchange of nutrients and oxygen and waste material occurs at the level of the capillary. And after the capillaries, fluid would go back towards the heart by being taken up by the veins, and actually even much more so by the lymphatic system, which runs parallel to the venous system. And in that way, the lymphatics help return fluid from the tissues back into the circulatory system. It has many other functions besides returning fluids. It also helps maintain local hormone levels, and very importantly, it is essential for normal lipid uptake. So if there are lymphatic problems or anomalies, disorders in the intestinal system, then we will not be able to absorb lipids in our diet, and that could lead to malnutrition and a host of other issues, and also chylous ascites, which means that lipids get leaked into what we call a peritoneum, which is the cavity in the abdomen outside of the intestine. And also, lastly, the lymphatic system plays a very important role in helping to mount an immune response. When we have bacteria, viruses, or some other organisms that are trying to invade our body, we have immune cells that try to break them up, and they rely on the lymphatic system to be able to take the broken up pieces of foreign body, that these bacteria and viruses, to the lymph nodes so that our body can mount the immune response. So you can imagine that if that process is disrupted and our immune cells cannot get these antigens to the lymph nodes so that we can mount an immune response, and we are at risk for infections that we cannot fight. And that is actually a complication for a lot of patients with lymphatic malformations. They're at risk for infections, cellulitis, and even in severe cases, sepsis. And so lymphatic malformations, or what we call LMs, actually very poorly understood. On the right here, you can see a histology picture where it says LC are actually very dilated and abnormal-looking lymphatic channels where the lymph fluid is sitting there. It is not well understood where these LMs come from, but our laboratory in the last year, we just published last year a paper in which we identified a progenitor cell population that probably gave rise to these LMs. And what it means is that potentially we have a target for therapy, and we can go right to the heart and to the origin of the matter and treat this disorder. And in terms of exactly how our progenitor cell gives rise to the lymphatic malformation, it's still incompletely understood, and we're working on this, and Dr. Shawber will talk more about this later. But because we very poorly understand how this whole biologic process is going on, our current standards of treatment, which include sclerotherapy, in which we inject sclerosins into these lymphatic channel spaces in the hopes of collapsing the lymphatic malformation, as well as surgery, which basically we just cut this out. While these are what standards of care today, it is an incomplete treatment, and recurrence is very common even after these treatments. So we know that we need better treatment options for affected patients. And some of the demographic and epidemiologic data, lymphatic malformations are considered an orphan disorder, which in the United States is defined as affecting less than 200,000 people. However, in our estimation and also research into the literature, the estimated incidence is actually much higher in every person out of 3,500 to 8,000. So it's a much higher incidence than I think what has been previously accepted. About 50% of them are obvious and present at birth, but by about 2 years old, 90% of them are diagnosed. In terms of some of the causes that are associated with LMs include chromosomal anomalies. And what I need to stress here is that some of the patients that do have chromosomal anomalies, such as Down syndrome, Turner syndrome, they have a syndrome in which LM is a feature. So, there are certainly patients who have LMs that do not have these chromosomal anomalies. And more excitingly, we have been able, our labs and others have been able to identify several genes that could be mutated in this disorder. And some of the genes we list here are known to play a role in lymphangiogenesis and lymphatic biology. More recently, PIK3CA has been a mutation that has been shown to be present in some lymphatic malformations tissues, and it's abnormally activated. And it's exciting because there's actually a drug that targets this mutation, and you can see why it's so important for us to understand the basic science so we can get better treatment for patients. LMs are otherwise classified based on the subtype and grossly separated into focal, multifocal, and also primary lymphedema. Focal LMs are usually a discrete, affects a discrete area in the body, and they can further be subdivided into a macrocystic, microcystic, or mixed LM. A macrocyst is actually a big sac of fluid you can see, versus microcystic, which it's much less well defined where the cystic spaces are. In terms of multifocal LMs, that's really for more extensive LMs that affect multiple areas of the body, such as a generalized lymphatic anomaly, GLA, in which it could affect the entire body or the entire half of the body, and Gorham-Stout disease, in which the LM is actually in the bone, and the bones that have LMs are very weak and they're at risk for fractures. And finally, I want to add that primary lymphedema is also considered an LM, according to the ISSVA Classification. And primary lymphedema affect patients usually in the lower extremities, sometimes can be in the upper extremities. They can present as babies, Milroy's disease, such as Milroy's disease, or when they are older, a few years older, and then in the lymphedema tarda, they don't even present until patients are in adulthood, sometimes even after age 35. And the big separation between patients with primary versus secondary lymphedema is that patients with primary lymphedema inherently have a disorder and abnormality in their lymphatic system versus patients with secondary lymphedema where there was either surgery or trauma to the area and that disrupted lymphatic biology. So in terms of clinical symptoms experienced by patients with LMs, it really depends on where in the body the LM is. For instance, if you have an LM in the cervicofacial area, you worry about infection, you worry about bony overgrowth in the jaws and malocclusion and dental issues, and if it is on the floor of the mouth, around the tongue or throat, you have to worry about airway issues and breathing. If it's in the mediastinum, which is really the chest area, if there's a lymphatic disorders and the lymph flow is not normal, the lymphatic fluid can actually get backed up and get dumped back into what we call the pleural cavity, which is the area between the rib cage and the lungs. And then we can have a lot of fluid build up in that area, and that can affect your respiratory status and breathing and oxygenation levels. If it's in the abdominal area, and I mentioned that earlier, we can have fat malabsorption and also chylositis, chiroperitoneum, really the same word. But again, it's chylous fluids in the area outside the intestines, but inside the abdominal cavity. And if it's in the extremities, that's usually what we see in patients with primary lymphedema or some other mixed disorders such as Klippel-Trenaunay disease. And what we are concerned about is the length and girth discrepancy from one extremity to the other, and that can have functional consequences in terms of walking around, doing any exercises, just in terms of ambulation status, and especially they can, and I'll show you some examples later on some other comorbidities. And then again, finally, as in Gorham-Stout syndrome, where the LM is actually in the bone and it weakens the bone, it destroys the bone structure, and those bones can be painful, and they are also at risk for fractures because they are so weak. And I want to show you some clinical examples of lymphatic malformations. So this is a well-circumscribed macrocystic LM. So you can see it's very subtle. The little child has a cheek that seems to be fuller than the other, and basically when you look at it and the red arrow on the MRI, you see a balloon that is a big cyst. You can imagine that one can surgically either take it out or stick a needle in there and put in some sclerostin to collapse this tissue. Again, both treatments would work very well, but there's always a risk for recurrence. And this is a little more complicated. I'm showing you an example of a microcystic LM in the floor of the mouth. And as you can see, the proportion of this child's face is very much affected, and you can see under her chin in the submandibular region where there's a lot of fullness. And notice her mouth is not closed because she cannot close her mouth. If you look at the x-ray, you see how the lower jaw is much more overgrown and bigger, so it's just impossible to close. And as a matter of fact, this child has airway problems and has to have a tracheostomy to breathe through the neck. So you can imagine this is causes a lot of functional issues. And this is the MRI of the child. And I want to point out the arrows are pointing out the areas where the especially in the right, you can see the lighted up areas is where the LM tissues are. Unlike the first example, you don't see that well circumscribed sort of water balloon kind of feature. And you can imagine, where would I stick a needle in there to sclerose it? It's much more difficult, and I think of it as almost a marbleized piece of meat. When you see the fat and the muscles all gel together, it's also surgically very difficult to take out. So none of our standardized therapy really can address this problem, and it again underscores why it's so important to get some other better treatment modalities. And then this is a mixed microcystic cervical facial LM. Again, you can see the facial disproportion, and then the difference is, now you can sort of really compare it. In the middle picture where the MRI is, the red arrow shows you what the macrocyst is. Again, you see that big balloon. You know you can stick a needle in there. And whereas the microcystic components you can see on the right in the yellow arrows. And you see a little asterisk is that macrocyst we were looking at, so you get a mixed picture. So you can see that we can maybe address part of our issue, but not really everything else. So it's a tough problem. So finally, and some examples are lymphedema and also its complications. So these are photographs of patients with lymphedema. You can see that one extremity, and actually the picture on the left side, you get bilaterals. Both legs have lymphedema. But really, all the other pictures, you can especially see the second to the left, the lymphedema. You can see one leg is bigger, wider than the other. You can see that it's more edematous when compared to the other leg. And in the third picture, you can see the girth is very different in terms of the width of the calf of the normal side versus the affected side. And finally, on the picture on the right, we want to show you some potential complications of patients with lymphatic malformations and lymphatic dysfunctions. So when the lymphatic malformations and the dysfunction are very close to the skin surface, then what can happen is that lymphatic fluid not only leaks all over within the body, but leaks through the skin outside of the body. And when you have that, you can imagine you have lymph fluid leaking out. It's very difficult to care for personal hygiene, and also those sort of almost weeping wounds can cause they're potential portals for infections, and if that's not caught early, can lead to even sepsis. And you can see some of the almost more crusty looking areas, they're hyperkeratotic skin changes. Again, that's what a typical LM in the skin can cause, and you can see it can crust, they can leak, and it's just a difficult life for affected patients. And then I can tell you some of the more exciting developments now is that we can actually tell if someone is going to have an LM even before they're born. It's a picture of a baby. Basically, we can actually see suspected lymphatic malformations by ultrasound during routine prenatal care. And if we do have the suspicion, then the mother undergoes an MRI, and from the MRI we can see the fetus, and we can follow and track the growth and response of this lymphatic malformation. And it's important because if we are worried about the airway, the patency of the airway in this little fetus, then it may change the game plan for the obstetrician in terms of how to deliver this baby safely. So I've just told you what LMs are and what all the problems are and how limited our ability to help these patients are, which, but at least I've identified the problem. And now my colleague Carrie Shawber is going to tell you about what we can do about this.
So today I thought that I would discuss with you is what we can do in basic research. What's basic translational research? How do we go from the bedside, the patient, do bench research, and then influence patient care at the bedside again? And this is the goal of our research group at Columbia University. So really, to develop a basic and clinical translational research group, our goals are to assess changes in cells derived from patients, which actually says, you patients who are there, you're the key to us understanding different lymphatic disorders. And even what we find from lymphatic malformations, we can actually apply to other lymphatic disorders. So just our studies are just the tipping point. Our goals are also to develop mouse models, because if we have mouse models, we can actually understand the pathogenesis or the development, what contributes to lymphatic malformations, but we can also start looking at different therapeutic interventions. We want to identify unique defects in genes and gene expression, so doing what's called precision medicine. Even President Obama brought this up recently as a huge initiative for the National Institute of Health. And then developing new imaging methods. So can we improve diagnosis and understanding response to therapies? And really the big emphasis for us is to translate our findings back to the patients to improve their outcomes and improve their lives. So how do we develop an LM mouse model using patient-derived cells? And we've done this very successfully, and as Dr. Wu said, we've recently published this in the beginning of the year. So what we do is we take patient tissues. The tissues are solid. We disassociate the cells, and actually each cell in that tissue expresses different proteins or markers on their cell surface. We take advantage of this by using antibodies or proteins that recognize these hooked up to iron beads. We can then use a magnet to separate these cells out. So now once we have the cells, what can we do with them? What we do is we actually go ahead and implant them into mice. When we implant them into mice, you can see there's an arrow here, and this is where the implant is. In the absence of cells, you don't see any cellular content, whereas in the presence of cells, you actually see blood flow as well going into the tissue. So the beauty of this system too is that here at Columbia we have the ability to do both high resolution ultrasound and MRI. So similar to what we're seeing in the clinical or in the patients, we can also look at and model in the mouse model. And then at the end of the experiment, we look at what we call tissue histology or the morphology. And here the white arrow points out a very abnormal dilated lymphatic vessel, which is very similar to what we see in patients. To the left is again that model blown up with an arrow pointing to it, and next to it is a patient with a microcystic lymphatic malformation, and we can see there's similar expression of proteins, but also similar abnormal vessel dilation. So now that we have a mouse model, and these cells, what do we do with it? Because now we can understand the genes and we can change them, but more importantly, can we try to identify better therapies to treat patients? So again, we start with the same isolated cells from the patients, but what we do is we take these cells in culture and we do high throughput drug screens. And in this case, we tested 3 different drugs. The drug in the red is actually a drug that's currently being used as a sclerotherapy, and we can still see here it kills off the cells. The drug in the blue, actually we want to have 100% death, so basically the line at the bottom had no effect on cell viability in this assay. And the drug 2 was a novel drug, and we actually saw that it also inhibited cell viability or killed the cells off in this assay. Now that we identified drug 2, what do we do with drug 2? We now go back to the mouse model and we introduce the drug into the mouse model. So we have mice that are either given what we call vehicle or control, so no drug, or they were given drug 2. And we introduced it, and we can monitor real time by ultrasound and by MRI as it grows. But then when we look at the tissue histology, here we got a striking result. So again, on the left, you see the control with the large dilated vessels, whereas on the right, what we have is drug 2 treated mice, where we now have nice collapsed, undilated, normal-looking vessels at a much lower density. So here you can see how patient involvement can actually lead to drug discovery and something that we could possibly eventually move into the clinic to see if we can improve patient outcomes. So the other thing I was talking about was precision medicine. So what can we do with precision medicine? And you probably hear this a lot. And this is actually understanding different individuals and collating their data in a way that we can actually identify important genes and targets to understand how LMs develop. So we could do 2 different studies. And here at Columbia, we have a genome center where we do it. We can do genomic analysis, and that's identifying mutations in genes or DNA. This is the coding material. Every cell has the same genetic makeup. So there's the DNA. The difference is that in every cell, not every gene is expressed. So we have to combine this with gene expression analysis. This is the genes being translated so that they make the proteins, which are the functional components. And here we identify changes in gene expression between different affected and unaffected individuals. Now we take this data and we do what's called bioinformatic data analysis. These are comparative studies, and what we can do is we can look at cells from affected and unaffected individuals. We can look at cells from different regions within the same individual, those who are areas that are involved or affected, or those are unaffected at different tissue sites. We can also compare DNA and RNA analysis to get a better picture. And finally, what is called pathway analysis, which is the exciting thing, really developed and extended at Columbia University. This is understanding how all the genes work together to try to find different targets for us to do therapies. So, the goal of this is to identify candidates so that we can study it back in our mouse models, but also to identify candidates because there may actually be therapies currently available to treat lymphatic malformations. So just to summarize, what bedside to bench to bedside is. It's an acquisition of patient tissue, so again, patient involvement is critical in this. It's then going to the bench, characterize changes in the cellular behavior and culture, and develop the LM mouse model to understand what is affected in different individuals. So each LM case may be distinct from each other. We do next-gen sequencing, where we look at genetic and gene expression profiles and combine those to get a better idea. We can use these cells to do high-throughput drug screens to identify candidate genes, and we can do the preclinical studies using our mouse model so that we can go back into the bedside. So, our goals by using these models and these cells is to improve diagnosis by coming up with new imaging methods to reduce cost and make it easier, and have a better idea how to look at drug responses in these patients. We could use genetics to help us diagnose, so it may be different people present the same way but have different genetic components and they need different treatments. So again, we can use the data to guide our treatment options and also for development of future clinical trials.